Well, good afternoon to whomever is watching. My name is Dr. Peter Catalano. I'm an otolaryngologist for about 35 years and was asked to discuss this topic, which is why children are prone to middle ear infections. And I think that it's very pertinent to a lot of healthcare these days, as you'll see as we go through this. Very common problem, certainly, and oftentimes poorly understood. So just looking at the incidence of otitis media, which is the infection we're talking about, we'll talk about what otitis media is in a moment. What's the incidence of this problem? Well, about 60% of kids will develop at least one such ear infection by age 3. And 75% will develop this condition or this infection by age 5. Very, very common. The peak incidence is early in life, and we're going to explain why that's the case. And about a quarter of these kids develop 3 or more infections during that time. You see these children getting infections over and over and over again. And again, you'll understand why that's happening once we go through the rest of the lecture. But the point is, it's a very common problem. Well, to talk about otitis media, let's first look at the ear, because the anatomy of the ear is very important in the genesis or the origins of the infection. So here we have a nice cross-section of an ear, and we have the outer ear here, called the pinna. We have the ear canal, and we have the eardrum. Now, the eardrum is not porous. It's see-through, it's transparent in most people, but it's not porous. So whatever's on the outside of the ear canal can't get through this to the inside. This space right here that I'm circling with my pointer is the middle ear. And this is the otitis media location. So otitis externa is external to the eardrum. Otitis media is behind the eardrum. And then there's an inner ear infection, which involves this spiral here, which is the cochlea, which is where the hearing nerves are, and or these loops, which are the balance canals. And these are inner ear infections. So you can have infections in the inner ear, middle ear, or outer ear. We're focusing on the middle ear right here. You notice that the middle ear is an air chamber that has little bones in here. And there are 3 little bones in here, colloquially called the stirrup, the anvil, and the hammer. But the medical term is the malleus, incus, and stapes in that order, the malleus being this big bone here, the incus in between, and the stapes here. And these vibrate with the eardrum to produce a sound, a fluid wave that goes through the cochlea and stimulates what are called hair cells to make sound. But we're talking about infection in this space here. This airspace has a connection called the eustachian tube, as you see here with my arrow. And this connection goes to the back of the nose. This is the back of the nose, often called the nasopharynx. This opening or eustachian tube pathway is not open all the time like a tube, as shown in the picture. It actually is a dynamic structure. And we're going to talk about more about that later. So it opens and closes. This is the key area for understanding infection in this middle ear space. And whenever this eustachian tube is compromised for one reason or another, doesn't open properly, gets swollen, gets clogged, you name it, it will cause a negative pressure to develop here. Because remember, the world outside our ear is always changing. The pressure is changing. You have high pressures, low pressure. If you ever watch the weather report, you'll hear them say there's a high pressure coming. There is a barometric pressure that's on the outside of our head that has to equalize to this middle ear space. The pressure has to be the same on both sides of the eardrum. Remember, the eardrum is not porous, so the air cannot go through the eardrum to equalize. So it has to use the eustachian tube, which is why we have it, to equalize pressure in this space with the outside world. So you're already getting to understand why things may go awry. As the pressure changes, If this eustachian tube doesn't allow the pressure to equalize behind the eardrum, then we have always a negative pressure developing in there. And that negative pressure sucks fluid, which is rich in glucose and proteins, into this middle ear space. And that's the fluid that's seen when you have an infection. And that fluid is like a candy store for bacteria and viruses and sometimes even fungus. And that leads to infection. So it's this system here of aeration of the middle ear that's the culprit for 99% of ear infections of the middle ear space. Now, how does this get compromised and why does this become a problem is what we're going to talk about. So that's the genesis of middle ear infections. It's what happens in this area along here, okay? Not what goes on through the ear canal. A swimmer's ear, which is an infection of the ear canal, cannot penetrate the eardrum. Equally painful, but unless there's a hole in the eardrum, nothing traverses the eardrum. So this is a closed space, okay? Now this is evidence of infection in that middle ear space. The image on the left of your screen is normal with aeration around the little bones, and here's the eardrum. And on the right, we have an inflamed eardrum, which is why it's pink in color. Our bones are still present, but this is all pus that's filling into this space, okay? And notice that the bone around this, we're going to go back a second, this all bone here around the ear, and this bone around the ear is porous, kind of looks like a pumice stone. You see all these holes in the bone. And this is very important. We're going to talk about this later, the consequence of this bone being porous. Now, it's porous for a couple of reasons. One, it's lighter, so you can pick your head up, but also it's stronger when you have lattices like this, so it makes it a very strong bone. But there are consequences to that in the world of infection. And you can see that infection might get into these little air spaces and can be difficult to eradicate as a result of that. But that's for later. We're going to get there later. So this fluid behind the eardrum is the infection we're talking about. The longer this fluid sits here, notice the eustachian tube here on the picture on the left is open, and on the right, you can see the pink color shows swelling of the mucosa, or lining of the eustachian tube, blocking that eustachian tube off from aeration. And that's how the fluid develops. So as we mentioned, this fluid in here is rich in nutrients, glucose and protein, and will lead to infection or growth of bacteria and viruses. Now, the longer this fluid sits there, the water inside the fluid gets resorbed, and you wind up with a very thick fluid we call a glue ear, which is gelatinous in nature, almost like molasses, and hard to eradicate. It's hard for the body to clear that. So infections in here that linger for several weeks are very difficult to eradicate. One of the reasons why we recommend early treatment for these infections. But the longer this sits, the longer the fluid is there, it's no longer fluid, it's more of a gel and difficult to eradicate. Now, so again, otitis media by definition is infection of the eardrum and the middle ear combined. It can be viral or bacterial, again, rarely fungal. And it occurs always due to eustachian tube obstruction. That is the overall genesis of otitis media. Now we're going to talk about what makes the eustachian tube obstruct, but that is the process that must occur for infection to occur. Otitis media causes pain, very painful, hearing loss because the eardrum can vibrate. The little bones are prevented from vibrating as well. Gives you a headache because it's right in your head, ring in the ear, tinnitus, imbalance because it can affect the balance system. Those air cells we showed you, the pneumatized bone of the ear, can get infected. And that's called mastoiditis. So the bone moves from the middle ear space, which is one big chamber, into all those little tiny holes in the bone called the mastoid bone, causing mastoiditis or infection of the bone, not just that air space, much more complicated infection. Infection of the mastoid or just the middle ear space can lead to brain abscess because the brain is very close. We're going to go backwards for a second. You look here, We have some bone. This is that middle ear space. We have some bone above it, but this bone thickness varies significantly. And some people don't have any, and the brain is sitting right on top of this middle ear space. Easy for infection to transfer from here into the brain, either through the bone or directly to the brain, because there is no bone here, and that's just an anatomic variation that we see. So that's how you get brain abscess, leading to also meningitis, which is infection of the fluid around the brain, which all of these can be lethal. And then facial palsy is another complication that occurs because running through here, right next to this stapes bone here, is the nerve, not shown on the picture, but the nerve that makes your face move. So if that bone, if that nerve is exposed to the pus for extended periods of time, you can wind up getting paralysis of the nerve to the face, which is a complication of otitis media. But most of these infections are contained to the middle ear space, thank goodness, and we don't have the complications occurring like this unless they are neglected or the patient has some kind of immune deficiency problem. Now, this is what an ear infection looks like, a middle infection, on examination. If you look with what's called an otoscope for light in the ear, you can see on a normal eardrum. So you can see it's transparent. You can look through it, and you can see little bones in here. That's what you're looking at here. And it looks like there is air there, like looking through a window almost. A little opaque, maybe translucent, but you can definitely see through it. And sometimes it's really crystal clear. B is an early infection where you still have some area here where you can see through it, but it's starting to get red and inflamed. You can see that. There's definitely a little bit of a bulging effect here to the eardrum. In image C, you can see the bulge very clearly, and there's no more air at all. This is all pus that is behind this eardrum, or at least fluid that is becoming grossly infected. And then D is crank purulence, and it almost looks like right here this eardrum wants to rupture and break through. The eardrum is very thin. It's 3 layers of tissue, 2 epithelial layers, one on the inside, one on the outside, and then a thin fibrous layer in between those 2. And so with long-standing infections, they can actually rupture through, which is a way of draining an abscess. Think of this as an abscess, and the body's way of draining that abscess spontaneously is by hoping you get a rupture or allowing a rupture of the eardrum to drain this infection. This is what it looks like. These are the different stages of it. The last stage would be a perforation, but these bulging reddened eardrums are what you're looking for compared to A, which is a translucent or transparent eardrum with no redness and a very clear, thin eardrum. Now, these are the causes of otitis media in children. We're going to talk about the anatomy a little bit more, about the eustachian tube anatomy, adenoid enlargement, bottle feeding in infants and children, acid reflux disease, childcare and daycare, teething, airborne pollutants, and immune dysfunction. And we'll show you how all of these, and sometimes there are more than one taking place at the same time, if not almost all of them, to cause a repetitive series of ear infections in children. Well, let's talk with anatomy first. Well, the first issue is the eustachian tube direction or angle. And what you see here on the left is a child, and you can see that the eustachian tube is near horizontal, almost in line with the external ear canal. Whereas in the adult, it is much more angled inferiorly toward the back of the nose as the head grows. So this angulation difference is very important. And I'm going to show you why the child is more prone to infections just because of the position of the eustachian tube with respect to or versus the adult situation. Now, not that adults can't get ear infections, and there are a bunch of reasons why adults don't get them as frequently as children. One of them, however, is certainly the angle of the eustachian tube entering into the back of the nose. And again, we're going to bring up why this angle is so critical and different and predisposing compared to the adult situation. Now, the eustachian tube itself is a functional tube, as I alluded to earlier. It's not open like a pipe. There are two muscles that open this eustachian tube. On the left, you see a closed eustachian tube. The blue is a rim of cartilage. The pink is the mucosa or lining of the eustachian tube, which looks like the lining of your nose or your mouth. And then there are two muscles. There's a tensor veli palatini, also called a dilator of the eustachian tube, and the levator veli palatini. And both of these pull in opposite directions to open up the lumen, or this black space. As you see this on the right, the lumen now is open. Now this is magnified. So this opening is only about 1 millimeter, at most 1.5 millimeters. It's not 4 inches. So it's a very small opening designed just to allow air to go up the eustachian tube and equalize the pressure behind your eardrum or in your middle ear space. If either of these muscles do not work well, and that is one of the causes of eustachian tube dysfunction, called neurogenic dysfunction. This can be due to the age of the person or genetics. What does this mean? Well, in infants, as you know, why can't they walk right away? Well, the neurologic system hasn't developed in a way that can control the muscles that are required for strength and balance. So the myelin sheath, or the coating of the nerves, think it has an insulation of the nerves, takes time to grow in an infant, from the brain all the way down into the perimeter, or periphery rather. And the same thing occurs for the nerve that goes to these two little muscles that open the eustachian tube. So in some people, the nerve that controls the eustachian tube opening is delayed in function. And so the tube doesn't open and equilibrate air pressure well. This can be temporary, or it can be permanent. It's always temporary in children because it doesn't work very well in infants. You see infants on an airplane, when the pressure changes are dramatic, and they're crying because they can't open their eustachian tubes easily on demand. You and I could by yawning or swallowing or chewing some gum or blowing our nose, but an infant can't do that. So they have difficulty if the normal neurologic control of these muscles is not mature at the time of this air travel. So this is one issue. The other is that it never really develops because of genetic issues, in that they have poor eustachian tube control. And this can be, you'll see this in people who have either unilateral or bilateral predilection for recurrent ear infections, even into teenage and adult years, because this eustachian tube never developed properly, and the muscles for opening are never fully developed or matured. And so you can see that again, unilaterally or bilaterally, but it does occur, as opposed to something related to the 1 to 2-year-old child. And that's why you saw the incidence of infection so high in the 1 to 2-year-old children, even up to age 3, because of this neurogenic delay in the neural muscular control of eustachian tube opening. So it all comes down to the eustachian tube, okay? So this is one area of a problem. Now, when the eustachian tube doesn't work for a period of time, as we just discussed, in children or even in adults, and the infection occurs in this middle ear space, and we talked about air has to get in here to break the cycle of the infection, the doctor will purposely perforate the eardrum and put in what's called a PE tube, which is a pressure equalizing tube. That's what PE stands for, pressure equalizing. So the pressure equalizing tube is placed so that the air can go now through the eardrum, which was not permeable before, and bypass this dysfunctional eustachian tube, either because it's swollen, or because it's obstructed from something else, or because it just doesn't open properly because the neuromuscular control is lost. And some adults have these tubes in as well for the same reasons. But that's the way to bypass the normal aeration function that is required to allow the middle ear to function properly. The air in here, the air pressure in here must be normalized one way or another for this ear to function normally and to avoid the repetitive cycle of ear infections. So this is one solution, okay? Now, the other big issue affecting the eustachian tube has to do with adenoids. I'm going to show you where adenoids live in just a moment. Adenoid enlargement, or we say in medicine hypertrophy, the adenoids are part of the immune system, as are the tonsils and the lymph nodes. The lymph nodes are little nodules, look like beans that are under your skin. You can feel them sometimes when they're swollen, but there are dozens of them, if not hundreds of them, throughout our body, and they filter immune cells and diseases from our body, be they infections or cancers, and can get swollen at times when you heard of swollen glands. That's actually swollen lymph nodes. But the adenoids are exposed lymph nodes. These lymph nodes are usually under the skin. They're buried, and you can't normally see them unless they're swollen. But the adenoids are exposed, and think of them as exposed lymph nodes living in the back of your nose. And so they are in your nose because that's one of the ways that disease enters your body. The tonsils are exposed lymph nodes as well, living in the back of your mouth. These are the only two ways that disease really enters into your body, at least with any frequency. And so that's why the immune system is developed to be in these two locations to filter out immune or diseases before they enter the body. However, the consequence of that is they can swell up. You have large tonsils, which you're aware of, strep throat infections, and large adenoids. And the large adenoids have two things. They are a mechanical blockage of the eustachian tube. I'm going to show you how that happens in a moment, as well as they harbor viruses and bacteria, which can then crawl up the eustachian tube. And that's also why the angle of the eustachian tube is important, because the more horizontal tube is a lot easier for viruses to traverse than a vertical one that you see in adults. So that direction of the eustachian tube, as we showed earlier, has some consequence here in terms of this. But the size of the eustachian of the adenoid can block the eustachian tube. I'm going to show you that in a moment. Now, normally, as we age, our tonsils and our adenoids shrink away and dissolve, and you shouldn't be able to see them anymore. Many times I look in somebody's mouth and I can't tell if they had their tonsils removed. I'll say, you ever had your tonsils removed? They'll say, no. So they just shrunk away normally because they weren't necessary anymore. The immune function has been survived already by the rest of the body, so they can shrink away. They're there early to help develop an immature immune system. But once that function has been achieved, we don't need them anymore, so they shrink away. But when they're big, they're obstructive, be they in the mouth for the tonsils or the nose as the adenoids. And here you can see in the image on the left where the adenoids live. This is the back of the nose, far back, and you can see that they can block breathing if they get very large. I'm going to talk about that in a moment, as well as blocking the eustachian tube. And the eustachian tube is sitting right under here, right underneath this red adenoid enlargement that you're seeing. So right in where the little groove is the opening of the eustachian tube. On the right is a X-ray, a lateral X-ray, a common way we use to look at adenoids to see their size. And the black here is air. Here are the teeth, upper jaw, lower jaw. This is the brain up here. And this gray bulge here is this adenoid bulge you're seeing on the left. And it's a gray is soft tissue on the X-ray. So it's a gray bulge here, which is the adenoid. And notice there is air here. So it's not blocking the breathing in this particular child, but it is large enough that probably it is affecting the eustachian tube, which is one of the reasons it was obtained. But we don't like getting X-rays all the time because we have to radiate the child to do this. So a different way of identifying enlarged adenoids is by using a scope called the nasopharyngoscope or an endoscope. These can be flexible or rigid, and the doctor will oftentimes numb up the nose a little bit or decongest the nose a little bit with a spray before introducing this light with a camera on it to look directly at the adenoid area and eustachian tube area in the back of the nose right here in the nasopharynx. So you can look directly at that instead of getting an X-ray to see if they're enlarged or infected with pus on them, etc. So this is a common thing, but again, difficult to do in 3, 4, or 5-year-old children who won't sit still. They'd rather have the x-ray because it's a lot easier for them. So it really depends on the child and the situation. In little children, you can hold their head and hold them down. And when a 1-year-old, 2-year-old kid, you can usually do the scope real quick. It takes about 10 seconds. But in older kids, they may not tolerate this well, or fear of it anyway, and the x-ray is an easier way to go. But imaging of that area can be very helpful and diagnostic. Now, these are children who have enlarged adenoids, causing them to have nasal obstruction and chronic mouth breathing. These children are guaranteed to have ear problems, but also look at their face. Notice it's narrow and elongated. Their mouths don't close because they can't breathe through their nose because the adenoids are obstructing their breathing. And children who have this problem with chronically enlarged adenoids develop what's called adenoid facies, called that because the adenoid is the problem, and the face develops an elongated structure. The teeth are prominent. You can see that both look like they have these over-enlarged incisors in the front, and the mouth never closes during daytime or nighttime. This is something you can pick out very easily in a child, whether you're in school or at home, if your child is developing this. This is really end stage, but children, as you see here, walk around like this, completely undiagnosed as mouth breathers. But this tells you that these children have adenoid obstruction, nasal obstruction. So nasal obstruction that we just saw leading to these adenoid facies is another reason for eustachian tube obstruction. Because when the nose is obstructed, it was shown by a doctor in Singapore in 2009, that when the nose is blocked, the eustachian tube will be squeezed closed. There's a negative pressure that develops in the nasopharynx, that area in front of the eustachian tube, that actually closes the two sides of the eustachian tube together. It sucks them closed, like sucking a wet straw closed. You know, we used to have those paper straws. If you sucked hard enough, you would suck them closed. The two sides of the straw would close. Well, that's what happens to the eustachian tube when you have nasal obstruction for any reason. So it challenges the eustachian tube for sure. So nasal obstruction can be present during sleep or when somebody is awake, and only during sleep sometimes, because when you lay down, you have the benefit, or you lose the benefit rather, of gravity. Gravity drains fluid out of the nose. So if there's swollen tissues in the nose, wherever they may be, they're going to be reduced by your head being upright. When you lay down to go to sleep, your nasal tissues swell. And this is pretty much in everybody, to some degree, some more than others. In a child, if that happens, it can lead to significant changes, such as mouth breathing. And mouth breathing for a child is really bad. It leads to what's called active sleep. You may see kids who are very active during their sleep. They move around. No one wants to be in bed with them. They kick and move, and they're all over the place like a fish out of water. It leads to teeth grinding or bruxism. It leads to snoring, and leads to frequent awakenings where they don't sleep. They wake up, go in their parents' room several times a night because they can't sleep. These are all due to nasal obstruction during sleep. So if a child has these problems and is also getting ear infections, you can bet they have nasal obstruction. And it might not even be adenoids. It could be a deviated septum, could be swollen tissues in the nose, could be other things, which we'll get into in a little bit. But this child has nasal obstruction to proven otherwise. The active sleep is because of adrenaline secretion during sleep. And when the children are sleeping and they're not breathing properly, the brain says, we're in trouble here, goes into a stress situation, produces adrenaline and cortisol. The adrenaline and cortisol then powers the muscles of respiration so the child can breathe through the obstruction, but also makes the child active because it also powers the muscles of the arms and legs. And the children move around a lot in bed because of the adrenaline effect. This adrenaline effect leads to ADHD in 50% of these children. So that's another thing. If a child develops ADHD, they have sleep-disordered breathing, nasal obstruction during sleep, and are prone to ear infections. If you look at the history of the kid, you'll probably find all these things present. So a child showing any of these symptoms should be evaluated. It's a complex area, But the signs are very obvious, very easy to identify, and often overlooked, as snoring, for instance, is thought of as healthy. That means the child is sleeping soundly. Totally wrong. That means there's an airway issue in that child. Grinding of the teeth, that's done because of increased CO2, which is carbon dioxide, in the blood during sleep. And increased CO2 because of poor air exchange, because of poor breathing, powers the muscles of mastication or the muscles of the jaw and makes them go into this grinding motion, which is a mechanism that the body has built in to improve airway. And by bruxing, you're not only causing the muscles of the jaw to be tense, but also all the muscles in the mouth that control the tongue. So the tongue doesn't become as floppy during bruxism so that it doesn't fall back into the airway and block you from breathing at night, something called sleep apnea. All these things are connected, but affect the ears in adults and children, but especially in children. Now, when the adenoids are enlarged, remember they sit right in the middle of the nasopharynx. So on this picture here, right here where I'm pointing to my pointer is where the adenoids sit, right between both eustachian tubes. So oftentimes both ears get affected from enlarged adenoids, not just on one side. If it's only on one side repeatedly, that usually means that there is a problem with this eustachian tube function. So that's a clue that there's some genetic dysfunction of this eustachian tube compared to the child who gets it bilaterally, because bilateral ear infections just is due to the presence of the enlarged adenoid, maybe harboring viruses or bacteria, as opposed to a function of the eustachian tube itself. Keep that in mind. Now, bottle feeding. Again, children laying down and feeding with a bottle, as you see on the left, big problem. Why? Because that eustachian tube is horizontal. And if any of this milk regurgitates, which often happens during feeding, up into the nasopharynx, the eustachian tube is right there, and the milk goes into the middle ear, believe it or not. So the child should be sitting upright, as you see on the right, about 45 degrees or more for bottle feeding. This way, nothing can go up into the eustachian tube, or at least it's much more difficult to go up into the eustachian tube than in a child who's left lying down like this on the left. Similarly, teething or hands to the mouth, which children frequently do, is another problem. Why? Because their hands are clearly not clean. They're touching everything. They're playing with everything. And they're putting this in their mouth, introducing bacteria, viruses, etc., into their mouth, which gets into their tonsil area and spreads to the adenoids. And then from the adenoids, we just talked about what happens. So again, children who are prone to putting things in their mouth and on their face will introduce bacteria and viruses to this area and make it more likely for them to have inflammatory conditions that affect that eustachian tube or the immune systems in the mouth and nose, which secondarily then affect the eustachian tube. And everybody knows this is true for daycare or indoor group settings in children. Look at the picture of the kids. They got things in their mouth. They're playing with each other. They're touching all the toys, transferring them from one to the other. So this is a germaphobe, wonderful situation here. Not a germaphobe. This is a germ party, rather, where the germs are easily spread from child to child and into the face and into the mouth. And again, difficult to control because you're not wiping these children's hands all the time, but something to be aware of. If your child's in daycare, they are prone to this because of the exposure of the germs to their head, neck area, face area, with the play styles and the interaction with children, which is important for socialization, but at the same time makes them prone to infections as well. Another common area is acid reflux. Acid reflux is very common in children. You can see that oftentimes the burping up of food that you see on the right is expected, but this shouldn't happen significantly after feeding. A little bit is okay to get some of the air out, but what if it's happening long after the feeding has taken place? Remember, what happens with refluxed food from your stomach is it can go all the way up into the nasopharynx. And what have we seen? Here's what the data on acid reflux in children shows. The prevalence in infants is 40% by 6 months. This is not the typical burping after feeding. This is reflux that is not intended. Reduces with age to about 5%. But children who are under the age of 10, at least 19% of them have acid reflux and have had acid reflux. So it's pretty darn common even up to age 10. I mean, many adults have gastric reflux as well, but I'm talking about in children, people don't realize it's equally common, if not more common, actually. The gastric contents can actually reflux all the way into the middle ear. So that fluid that has been seen behind the eardrum that we showed earlier on some of the pictures, well, studies have shown that if you sample that fluid at the time of putting in those PE tubes and they suction out the fluid when they put the tube in, that fluid, when sent for evaluation, is made up of acid and pepsin, which are digestive fluids from the stomach. So that's another issue with that eustachian tube direction. Again, if it was more vertically oriented, it'd be much less likely for the gastric contents to enter the middle ear. But because the eustachian tube in children is more horizontal, any reflux material can easily get up into that middle ear, especially if they lie on one side or the other, and cause repeated ear infections. It can also cause just inflammation and obstruction of the eustachian tube opening without getting into the tube, going up into the middle ear. But the point is it can. With an open eustachian tube, it can go right up into the ear itself, obviously causing an infection once that happens, because pepsin and acid from your stomach are highly inflammatory and cause all kinds of swelling wherever they happen to be, except in the stomach where they belong, because the stomach lining is designed to control them, but the lining of the mouth and nose and eustachian tube and middle ear are not designed to tolerate pepsin or stomach acid. So the treatment for this reflux usually involves changes to one's diet or feeding habits, like we mentioned in infants. Sometimes in children who are 4 to 10 years old, it might require something called an H2 blocker, or Pepcid is an example of that at 10 milligrams or less at bedtime, because lying down is when you're most likely to reflux in the evening. Or something called reflux wrap, which is a salt gel, much safer. It's the only product that actually stops reflux. Adults can use this too. So the other medications, the H2 blockers and the proton pump inhibitors, they are designed to reduce acid production. They don't do anything to the pepsin, which is the digestive enzyme. They just reduce acid production. It doesn't actually stop reflux from occurring. It just reduces the acid in the reflux material. Reflux rest is the only treatment that stops reflux from actually happening by preventing it from going up the eustachian tube completely. And some congenital issues require surgery. So on the left here, you see normal reflux is just an incompetence of the valve at the bottom of the esophagus here. And when it's open, acid can go through that. And one of the foods that causes this dilation to occur is caffeine. Now, children don't usually have coffee, often don't have tea, but they do have chocolate. And caffeine is in chocolate. And so caffeine use in the evening is very bad for children because it dilates the lower esophageal sphincter and predisposes them to acid reflux. And some people have congenital problems where they have herniation of the stomach through the diaphragm, causing a hiatal hernia, which then allows acid to freely go up into the esophagus. This is the more of the congenital variety. Some children do have this, a lot of adults have this, but oftentimes it's just this incompetence of the lower valve, which again is a maturity thing in some children. We talked about neuromaturity earlier with the eustachian tube. Well, the same can occur for sphincters, and this is one of the sphincters that's causing a problem. That's why bladder and bowel training is difficult in children. They don't have the neural control there. Well, the same thing can occur for the sphincter of the stomach. And PEPs and caffeine, again, is one of those things that makes this difficult to control in anybody. The next issue is airborne chemicals, cigarette smoke being the number one. Not that children smoke, but secondary smoke is the most dangerous of all because it's unfiltered. And if you're in a home with smoking or outside among people who smoke, this is bad for children because they inhale it, goes right into the eustachian tube area. Adenoids can get enlarged. Eustachian tube itself can be irritated by this. So avoiding cigarette smoke and other airborne chemicals, which is why children shouldn't be in factories, etc., is also very important, and that's easy to control. Another one is allergic rhinitis. Does your child have allergies? Because allergies cause the same congestion in the nose and cause children to blow their nose. Well, if you're blowing your nose, what are you going to do? You're going to blow things up into that eustachian tube because it goes both ways. You know, the nose is open. There's an opening in the back and an opening in the front. When you blow, you're trying to blow things out the front, but that's why your ears can pop when you blow your nose, because the air can go both directions. And children can actually blow things into their eustachian tubes and into their ears. And here with allergic rhinitis, you can see that the inflammation of the nose goes all the way back to the eustachian tube area, causes nasal obstruction here, which we said causes problems with the eustachian tube earlier by that negative pressure, or the inflammation can go here, or the drainage of inflammatory mucus can go past the eustachian tube, all of which inflames the eustachian tube and causes ear disease, because that eustachian tube is very sensitive to all of these things that go on. So allergies are another thing to identify and control if your child has them. And not every child looks like this. Some children do not look like they have allergies until you test them. And it can be food allergies, but we're really talking about airborne allergies here as a dominant issue. So allergic rhinitis, I have a couple of minutes left here, is usually thought to be mediated by IgE, which it is, but what starts the IgE is actually a neurologic event. So allergies are actually neurologic. What that means is when an allergy or an allergen hits your nose, the cranial nerve 5, which is a sensory nerve in your nose, picks up the fact that there's something in your nose. It sends it to the brain. Hey, we have something here. The brain decides it's going to react or not. If the brain says, hey, we're going to react to that for any number of reasons, there's another nerve called the posterior nasal nerve, which sends a signal to the lining of the nose to make mucus and swell. That is a neurologic event. It has nothing to do with any chemicals at this point. It's a pure neurologic event. Once that posterior nerve fires to cause swelling, it then releases a whole host of mediators like IgE and mast cells and all kinds of inflammatory mediators to try to react and prevent whatever that product is, that allergen is, from getting into your body. So it really is a neurologic event. The sprays we take and medications we take for allergy are trying to control the secondary event, which is the chemical release from the neurologic event, which is the primary event. So we now have a way to treat the primary event using either cryotherapy or radiotherapy or lasers to interrupt the posterior nasal nerve in the nose and reduce this neurologic response to allergy. It's remarkably effective in a whole host of people. We just published a paper on this in children over 5 years. It works really, really well, avoids the need for medication in most, not all. Some still need some medication, but it's still very, very effective, and it really gets to the root of allergy as opposed to chasing you with medications, which is after the event has started. And lastly, we get to immunodeficiency. Some children will develop an immunodeficiency from the chronic infections that they're developing just because they've burnt out their immune system from chronically being acted in all the infections and flus they get. Or it can be something congenital where there is actually missing mediators or missing components of the immune system that are not working properly. This is easy to tell by a simple test that can be done in the office. The number one test we use is something called the pneumococcal antibody deficiency test. So you do a pneumococcal antibody assay. It's 23 antibodies that are done with a blood test. If the antibodies come back low, which is common in children with repetitive infections of any kind, whether it's tonsils, nose, sinuses, pneumonia, you name it, they will then get a pneumococcal vaccine, which replaces all of the antibodies they are missing until their immune system can start making them again. And we usually repeat the antibody assay in 6 months to make sure that the immune system is active properly. And sometimes the vaccine has to be repeated because it doesn't take the first time. That's not common, but it does occur, which is why you need the repeat assay at 6 months after the vaccine has been given. So keeping in mind pneumococcal antibody deficiency or other type of immune deficiency can be tested for, but this is the most common, easily treated, and makes a big difference in the child's outcome once identified. So in summary, these are the issues that affect the eustachian tube. which is the cause of otitis media and why children are prone to ear infection. Went through the anatomy, the adenoids, the bottle feeding, the teething, the daycare, the acid reflux, the mouth breathing, the nasal congestion, the allergies, the airborne chemicals, immunodeficiency, all affecting eustachian tube function. That's the key. All these things affect the eustachian tube. They don't affect the ear directly, and that's where the problem occurs. So I now open up the floor for questions. I hope I didn't go too long. Hopefully we have some time for them. So Christina, I will leave it up to you to see if there are any questions.
Yeah, I did get some questions. The first one is, what do you suggest as preventative measures?
Well, again, all this depends on the child, the age of the child, correct? And so I mean, some things can't be helped, right? If you have to put your child in daycare, you have to put your child in daycare, right? Those are things that you can't avoid in some situations. Teething is a natural process, so as best you can, clean what you give your child to teeth on. But just, I mean, those are things that you can potentially intervene with if you're the one taking care of the child at the time. Bottle feeding, again, knowing the right position, that's something you can do. You can take care of. Getting tested for allergies is something that can be done. And whether it's medications or things, those are things that you can be proactive about. Is there reflux in your child? Any evidence of that? If there is, reflux wrap is the easiest thing to use. It's over the counter. You buy it online. It's a gel. It tastes pretty good. And it really works. It's the only thing that forms a barrier in your stomach to prevent the reflux to occur. You can't do anything about anatomy, right? Your anatomy is your anatomy. So if your eustachian tube never developed properly, there's not much you can do about that. But identifying that might be the problem because of a recurrent unilateral problem, no real presence of big adenoids, why is that ear always acting up? Does it extend into teenage years, etc.? That lets you know that there's something else going on. The first thing I ask an adult when I see them for an ear problem is, when did this begin? Did you have ear problems as a child? If they do, and it's repetitive throughout their lifetime, there's some congenital developmental problem with that ear. So that's not something you can prevent. So preventing ear issues, again, there are so many different aspects you just went over. You can address each one of them, and they might all not be relevant in your child. But if you look hard enough, you'll probably find some of these that are active, especially the stuff with lying down at night and the refluxing that you don't know is occurring because your child is sleeping.
Okay, the next question is, how do you tell if an infant has an ear infection if they aren't showing any signs of like an infection?
Okay, so the most common signs, as we said, were fever and pain. They're crying, they're uncomfortable. Older kids might pull at their ear, but little infants don't usually do that. You're not going to easily be able to look in there, although they do have these little micro cameras now that you might see online about the size of a pen that you can hook up to your phone and look in an ear and see if it's red and inflamed. But if there's wax in there or something, you won't be able to see that. So sometimes you don't know, right? Usually fever is the number one thing, where the child doesn't seem, they're ornery, they're grumpy, they're more likely to cry and things that they normally wouldn't do. So behavior is a clue to some of that. Some children don't get infections, or if they are infected, they get treated with medication. Now the infection is gone, but the fluid remains. So they still can't hear. So one of the things to do is test your child's hearing. Okay, rub your fingers next to them, next to their ear, like this. Do they respond? Or call them on the left, call them to the right. Do they turn to you? If they can hear, then they may not have fluid in that ear, or an infection in that ear if you think it's inflamed. But other than if they don't have the signs, then you'd have to look or have somebody test their hearing or do something that's more objective if they don't show signs of the infection.
Okay, the next question is, my child tends to get ear infections often. Will anything happen to my child if these recurrent ear infections go untreated or are improperly managed?
Absolutely. I listed some of the complications that can occur medically in terms of the ear itself with, ongoing infections, severe infections, but also there's learning disabilities that go along with this because the children don't hear. They miss a lot of school because of that. So loss of time from school, the dependence on antibiotics, which are no good for your overall immune system and your GI tract. So, if your child is having recurrent infections, the first thing I would do is get an immune test to find out if they have immune dysfunction, as well as the other things we talked about looking at. But it's likely that there's answers along the way for everything I showed you. But yes, there are definitely consequences to your child in development based on, again, how things play out with this ear infections that they have.
At what age do you recommend allergy testing?
Can
Is
be
there
done
like
at
a
any
too
age.
young of an age?
Allergy testing can be done at any age. I mean, you see children who have certain formulas and develop rashes or diarrhea from the formulas, and you know that, hey, there's something wrong with that formula. So allergies can be present early on. Now, you have to go to a pediatric allergist or an allergist. Most allergists deal with children as well, but definitely you can do that any age if you're concerned about allergies. Typically, they start testing over age 6 months, but you can test sooner if necessary based on what's happening. Usually you don't have a pattern of behavior before 6 months unless there are rashes or, like I said, diarrhea or things that are real obvious early on. But usually by 6 months, you can get it tested.
Are there any negative side effects to removing tonsils and adenoids on a child?
After age 2, the adenoids and tonsils have served their purpose, meaning they have provided enough immunity to that child that they're no longer necessary and then become more a liability than a benefit. So I always tell parents, I'd like to leave the adenoids in and tonsils till age 2, which is usually not a problem, especially for the tonsils that usually don't become as problematic that early, but the adenoids can. But if they're still having problems by age 2, then they should come out. No downside after that.
The next question is, are there any specific dietary or lifestyle changes that could help strengthen a child's immune system to combat frequent infections?
Well, as we hopefully know by now, balanced diet is the key. Sugars are not good. Sugars really have a deleterious effect on our body in general. Glucose out of control makes cortisol go out of control. And cortisol is a hormone, a stress hormone. We talked about that when kids sleep. So a lot of sugars cause a lot of cortisol to be produced to manage the sugars. And cortisol is an immune depressant. So it reduces immune function. So you don't want a lot of cortisol around. It's a problem. So it also leads to other types. So on one hand, it prevents you from fighting infection, but at the same time, it causes inflammation in the body. So it kind of has a double-pronged negative effect. And that all comes from poor diet, a lot of sugars, a lot of processed corn syrup in foods that you see, and a lot of what's called linoleic acid, which is corn oil, um, those types of plant or seed oils are very bad for cooking and for eating. So foods that have those types of seed oils in them and sugars cause lots of problems with diets.
That's all for questions.
Great. Well, thank you
Thank
very
you,
much.
Dr.
So
Catalano.
you're welcome. I think we're right on time. Look at that. 1 o'clock, almost.
All
Well, I hope
right.
this was helpful. You have it now in your repertoire of lectures, and hopefully it'll be helping some people. Thanks again, Christina.
Thank you.
Good luck, everybody.
Bye-bye.
Bye-bye.